to get her mic down?
Gotta cut it off. Just press and hold that button. You're live now.
Yeah, you might as well keep it on. I'll
Okay.
introduce you and we'll go.
Guys ready? Position. Change it. Forward and backward. Laser point.
Well, perfect. Thank you very much.
Okay. Good afternoon and welcome to the DCRI Research Conference. Before I introduce today's speaker, I'll just remind all of you that each of the conferences are taped in their archives. So you can go on to the DCRI front page and it'll direct you to the archives so that you can watch something that I frequently do. You'll see the slides. That's a great resource for review. We're also streaming, so for those of you that are sitting comfortably at your desks and watching remotely, welcome to the conference. It's okay if you come here as well and join us, but as long as you have the benefit of hearing our speakers. So today's speaker is a friend and a colleague, Laura de Castro. She's an associate professor of medicine in the Division of Hematology. Laura completed her Hem/Onc fellowship at Yale University before coming to Duke, and she is established and is the director of the Sickle Cell Clinic at Duke University, a large clinic that serves the tri-state and its patients. In reading through her CV, it mentions that not only is she involved with the investigation and care of patients with sickle cell disease, but also other hemoglobinopathies and what we call benign heme. So one of the few people, and it's somewhat of a vanishing breed of very, very important individuals who choose to follow a direction that is non-oncology. That being said, for those of you that have been involved with the care of patients with hemoglobinopathies, you know that it's everything other than benign. So I've asked Laura to come today and talk a little bit about research platforms, unmet needs, and opportunities in the investigation of patients with sickle cell disease. So Laura, thanks so much for joining us today. Much appreciated.
Thank you, Dr. Becker. Thank you for the invitation. I really appreciate the opportunity to talk a little bit more about what is my passion and my both clinical and research interest. So over the next 45 minutes or so, I'm hoping to accomplish the following. First, I'm going to outline basic information about the definition of sickle cell disease, the pathophysiology, and issues concerning areas of unmet needs in regard with research on treatment, diagnosis, and cure. And then I'll discuss a few studies either completed, on the way, or planned, highlighting some of the areas that we are interested in furthering our knowledge about sickle cell disease. And I will conclude with discussing some other areas that may be of interest for future investigator, or especially in the way of collaborative research in the area of sickle cell disease. So as you may know, sickle cell disease really was described more than 100 years ago when a medical student in Chicago described those phony, unusual blood findings on the blood of a dental student in Chicago that was from Grenada. And what they described, Dr. Herrick, was the presence of these red cells that had an abnormal shape and that were giving the patient severe anemia. So this description again was published in the Archive of Internal Medicine in 1910, so more than 100 years ago. And sickle cell does constitute the first disease where the genetic abnormality was clearly discussed. Sickle cell disease belongs to a group of diseases called hemoglobinopathies, so are diseases that are associated with an abnormal hemoglobin. And as we see here, and we know, the hemoglobin is mainly in charge of transport of oxygen and CO2, so has a very important role inside the red cell and constitute most of the red cell. Most of the human variants are considered benign or are not clinical significant, but most of them again result from a single amino acid substitution either on the alpha chain or the beta chain of the hemoglobin molecules. And again, most of these disorders are inherited with an autosomal recessive type of genetic inheritance. This graph here is basically shows the chromosome 11 where the different exons, but a group of illnesses characterized by the presence of that abnormal hemoglobin called sickle hemoglobin. The form that is most common and the most severe is the homozygous form, which is sickle cell anemia, but there are some other forms called double heterozygous that in fact are present very in high frequency in our state, in North Carolina. Some of them are the sickle beta thalassemia, which is characterized by the presence of sickle hemoglobin and another hemoglobin abnormality, beta thalassemia. The SC disease, which is also a double heterozygous condition, and the SD disease too. Rarely we find these other types such as sickle or Arab and the sickle with hereditary persistent of fetal hemoglobin. We usually diagnose this abnormal hemoglobinopathy by a hemoglobin electrophoresis, and what we see is that a red cell on an adult person should be constituted by more than 90% of the hemoglobin being the normal hemoglobin, what we call hemoglobin A. And that red cell should also have a small amount of what we call hemoglobin A2, which is also considered normal hemoglobin, and a little bit of fetal hemoglobin. What we see in the severe form that I mentioned before, the hemoglobin SS disease, is that these individuals have no normal hemoglobin or hemoglobin A, have a small amount of this other type of hemoglobin, hemoglobin A2, but most of the hemoglobin is that sickle hemoglobin, which gives them that homozygous state. The double heterozygous state that I mentioned before, SC is basically constituted by half and half S and C. And those patients with thalassemia, what they have is an abnormal production of this otherwise considered normal hemoglobin, which is hemoglobin A2, that give them also more fragility and low survival of those red cells on top of the presence of the sickle hemoglobin. The difference between the beta plus thalassemia and the beta zero thalassemia is that the beta zero on top, is that these individuals do not have any normal hemoglobin, versus these individuals that have a little bit of normal hemoglobin, enough to help those cells live longer and better type. So sickle cell disease has always been described as a disease with a high morbidity and mortality. And this curve, which was published in 2005, shows that in the x-axis of age in years, the survival of patients with these disorders significantly decreased, especially after the third decade of life. Furthermore, but positively, recent studies in young adults have shown that different than what we used to look in the past, which is similar, which is depicted here by the Jamaica cohort, where kids will die very early in life. Now, the sickle cell population, and this blue line and the red lines are the Dallas and the London population. The sickle cell patients are now surviving childhood due to significant improvement on preventive therapies such as hydroxyurea and prophylactic antibiotics such as penicillin, which has now been established as a standard of care for kids as young as 3 months of age. Still, this disease carries significant morbidity and mortality throughout the life. So in kids 20 years or longer, or 20 years or less, Powers show in 2005 that the morbidity mainly, at least 1/3 of them has to do with infections, but also acute issues such as a stroke, CNS events, acute pulmonary disease, irreversible organ damage, and then other multiple issues including trauma, hyperesplenism, and unknown causes. In our adult population, and as I mentioned, more and more individuals with sickle cell disease are now living on to the adult years. What we see most is irreversible end organ damage. So these patients present with one or more associated with the high morbidity and the high mortality of this patient population that we need to address with better treatment, better interventions, and hopefully a cure. So looking into the the pathophysiology of sickle cell disease, I mentioned that the defect is here with a single amino acid substitution that cause these polymers of sickle cells to react in a abnormal way, and instead of remaining these molecules separated, individualized, they tend to polymerize, changing the shape of the sickle cell from that nice biconcave shape to this sticky, abnormal, and very rigid red cell. And when that red cell is trying to flow to small vessels, then it has abnormal interactions with the white cells and the platelets, and also with the endothelial lining in a way that I'm going to hopefully show better in the next few slides. And that causes the hallmark of the disease, which is vaso-occlusion. So this graph on your right basically depicts again those red cells flowing into the vessels and having a normal red cell interaction with both the endothelium and with other blood cells such as the white cells and the platelets. And there's multiple factors that have been outlined and been associated with this vaso-occlusion. Some has to do with the red cells, some have to do with the environment, and some have to do with other cells that participate on that. Currently, sickle cell disease from the pathogenesis point of view is considered an endothelial disease. So what we see here is that the sickling that occurs because of the abnormal red shape and the poor hemoglobin performance then cause vaso-occlusion, cause issues with reperfusion injury, and then this is associated with chronic vasculopathy, chronic vascular damage. But also we have, due to the ongoing hemolysis and red cell breakage, changes on the NO and CO2 managed, and then this represent a problem with the balance and the vasoresponsive state. Furthermore, we know that red cell abnormal adhesion to the endothelium and interaction with white cells and red cells is highly associated with inflammation. And then there's also components of coagulation abnormality and platelet activation that all interact on this really complex pathophysiology. So, from the point of view of the red cell, back to the red cell, we again know that the cell dehydration causes problem with the rigidity and the dynamic flow of the cells. The polymer formation then causes mechanical occlusion, which is again the main description of problem with red cell. The early red cells called dense cells or young reticulocyte counts are associated with increased expression of adhesion receptors and then activation of adhesion receptors. There are issues with changes on the surface markers, and then there is a significant thrombogenic potential associated with sickle cell. And there are, again, adhesive abnormalities due to abnormal interaction of the red cell with the endothelium. So, given the complex and multiple steps of the pathophysiology, there's a lot of areas for us to do research on and to look for resolution on these issues. An area, again, is the adhesion of the red cell. What other inciting events cause that, such as dehydration, infection, etc.? What happened with the endothelial activation and vascular tone? What are the components of inflammation and hypoxia? How does hypercoagulability interact with this? And again, red cell polymerization by itself, hemoglobin S polymerization. This slide basically outlines some of the traditional approach that has been done towards sickle cell research. One is, again, looking at inhibition of the hemoglobin polymerization, and I will talk a little bit about hydroxyurea because one is the only FDA-approved drug to treat sickle cell, and second, the studies that prompted the approval by FDA of these drugs were really very unique and has served as an example of other studies to do drug development. Gene therapy is, because of the genetic etiology of sickle cell, is an area that is actively being followed and pursued. We were expecting 10, 15 years ago to have better outcomes in gene therapy than we have now. Still, but I think it's an area that is very actively, that needs to continue to be actively pursued. And I'll talk a little bit about bone marrow transplant. The bone marrow transplant team here at Duke is very strong on pursuing different ways of using bone marrow transplant as a cure for sickle cell disease. So I'm going to outline in the next 15 minutes or so, 5 minutes or so, a little bit about hydroxyurea because, as I mentioned, it's really discovering of this drug, which is an antimetabolite drug used for treatment of malignancies such as polycythemia vera and CML, chronic myelogenous leukemia. The discovery of its use in sickle cell really has been a hallmark in regard with how we treat this patient population and how we look into drug development with, against this disease. So hydroxyurea is an antimetabolite that mainly works as arresting DNA synthesis, but also work on arresting cell proliferation at the G1S phase. Its anti-cycling effects are multiple. The one that is mainly quoted and mostly used for research is that it allows for a shift at the erythroid level of production of hemoglobin, and patients treated with hydroxyurea have an increased production of both fetal hemoglobin and the percentage of red cells that have fetal hemoglobin within it. There is really no effect of this within the gene. This is believed to happen at the protein level. It does help decrease sickling by increasing the hydration and the formability of the red cell. It also, one of the main roles of hydroxyurea is causing decrease of white cells and platelet. It's an immunosuppressive. And by decreasing white cells and platelet, it does work as decreasing the red cell interaction that with activated platelet and white blood cell that is so damaging and is has been so well documented at causing vaso-occlusive episode. And lastly, again, it does decrease the interaction of red cells to the endothelium and the generation of nitric oxide, which has been postulated as another component of the etiology of sickle cell disease pathophysiology. So the initial study on sickle cell disease, where we participated more than 20 years ago, basically involved 299 patients with sickle cell disease. And this was a multi-center trial that needed to be stopped earlier because of the significant response on those patients on hydroxyurea versus those on the placebo arm. So what that study showed is that hydroxyurea reduced by nearly half the frequency of hospitalization of patients with sickle cell disease and the incidence of the main complication of sickle cell disease, which was pain, acute chest syndrome, and the need for blood transfusion. The study also showed that not everybody responded to hydroxyurea, but those that responded, called the good responder, have decreased hemolysis and also, again, as I mentioned, have decreased white blood cell count, which were all positive outcomes in regard with the pathophysiology of the disease. Patients treated with hydroxyurea show an increase of the fetal hemoglobin from 5 to 9%. And this again prompted the approval of this drug as by FDA for treatment of sickle cell in those individuals with 3 or more painful episodes per year. We did a follow-up study, and Duke participated on that, where we look at what happened when we treat patients long-term with hydroxyurea. Again, because it is a cytotoxic medication and there is a risk of teratogenicity, we were concerned about what happened when this patient is treated for 10, 15, 20 years, especially because the literature on hydroxyurea on polycythemia vera showed that there was an increased risk of developing secondary malignancies, such as leukemia, on patients with polycythemia vera treated long-term with hydroxyurea. So what long-term studies show, and these were patients treated as long as 17 years, is that the cumulative mortality of patients treated with sickle cell, and I apologize for this, was much less on those with higher fetal hemoglobin than with those with a low fetal hemoglobin. And that, again, the presence of the occurrence of acute chest syndrome and painful episode on those patients not treated with hydroxyurea was associated with increased mortality. The myelosuppressive effects that happen with hydroxyurea are dose limiting and is still very important for indication and for maintenance of patients of hydroxyurea. But really, there has not been significant evidence that hydroxyurea is associated with increased malignancy in patients treated long-term. What this study also shows is that patients treated, the longer the patients are treated with hydroxyurea, and this is these 2 lines, the better survival and the decreased mortality that we see. So over time, treatment with hydroxyurea as compared with those never treated or those treated for less than 5 years, it significantly impacts the morbidity and mortality of patients with sickle cell disease. And again, it also shows that in regard with causes of death, patients on hydroxyurea had much less frequency of complications such as a stroke, liver dysfunction, acute chest syndrome, etc., than those not treated with hydroxyurea. And again, this patient also, this graph is from another study done in Greece, where they follow patients for up to 20 years with treated with hydroxyurea, and contrary to the hydroxyurea initial study that was only done on patients that were SS, so the ones with the higher severity and with the worst disease. This study basically took all comers, patients with SC, with S-beta thalassemia, and they were all able to see that patients with receiving hydroxyurea have really improved survival in years than those not receiving hydroxyurea at all. The problem with hydroxyurea, and I apologize for this poor representation of the slide, is that there is a significant issue with compliance with this medication. It's one of those medications, like the blood pressure medication that we all have to take, that works when you take it. It doesn't work when you don't take it, but the effects are not seen immediately. So, you know, we have a headache, we take an aspirin, the whole headache goes away. We have sickle cell disease, we take hydroxyurea, we don't see the effect right away, we see the effect over time. So we are completing this study, which basically shows that there is a significant percentage of no adherence of patients taking hydroxyurea, even on those that understand what are the indication for hydroxyurea and why they should take it. So we need to look for different mechanisms and different interventions to try to, and we were able to report that beta-2 adrenergic receptor blocking was associated with blocking of the action of epinephrine in that red cell receptor. So we did this small study, which was a prospective non-randomized study, looking for use beta blockers as anti-adhesive therapy for sickle cell disease. And the endpoints were basically simple, was basically test if we could administer a dose of propranolol to patients on a steady state and see if we can regulate adhesion, and also we wanted to get some safety data because patients with sickle cells tend to be normotensive and sometimes hypotensive, and a beta blocker such as propranolol, one of their mechanism of action is causing hypotension, and we wanted to make sure that we were not causing more complications to the patient. So what we were able to show is that in this composite, patients that that their red cells were stimulated with epinephrine had a much higher adhesion than those not stimulated, and that on a dose-related matter, propranolol was able to decrease the adhesion of red cells to the endothelium. So this is a low dose, to a mid dose, and a high dose. And what we were able also to show is that from the point of view of safety, propranolol did not cause significant changes on blood pressure or a heart rate to the point to be clinically significant for this patient population. We just finished enrolling 2 weeks ago the last patient on this the follow-up study, which is basically looking into long-term chronic use of propranolol in this patient population. Basically, we were looking for, again, quantification of red cell adhesion and changes on oxygenation, hemoglobin parameters, by treating patients for 6 weeks with propranolol and then with placebo or vice versa, so each patient was their own control. And we're looking forward to really analyze the data and review it as the next step to really look into the role of inhibiting adhesion for management of sickle cell disease. We also have been very involved with a study that also recently finished, the phase 2, looking into adhesion components from the point of view of the endothelial cell. And basically we're looking for endothelium-like receptors. So this component, which is GMI 1070, is a selectin binding pan-selectin antagonist that is known to inhibit selectin binding in vitro and selectin mediated effects in vivo. This study was, to this point, there's no other selectin antagonist drug that has been really used in sickle cell disease. So this study really was the first one that looked into decreasing red cell adhesion to endothelium by modifying the adhesion from the endothelial point of view. So the phase 1-2 study basically looked into safety of multiple doses of this medication and pharmacokinetic studies, as well as biomarker studies of adhesion, inflammation, and downstream effect of this drug in adults with sickle cell disease. And what this study basically showed is that there was an inhibition in adults with sickle cell disease of adhesion that then resulted in a decrease of the soluble adhesion marker, decrease of leukocyte activation, decrease of cell aggregate, and decrease of markers of coagulation cascade. This really effect was noticed to be to last beyond the drug clearance, and also suggested that this selective inhibition really could play a role in decreasing cell activation and aggregate formation, and even in decreasing coagulation markers. So the study that we recently concluded, and Duke was one of the higher enrollers, basically was a multi-center study looking into the efficacy of this drug during an active vaso-occlusive episode. So we gave, when patients were admitted to the hospital with an active, non-complicated, painful episode, we give this medication IV for up to 7 days. And this is basically the top-line report, since we concluded these studies just 3 months ago, that show that treatment of patients with this substance caused reduction in the duration of vaso-occlusive crisis, decrease in the duration of the length of the hospital stay, and very interestingly, reduction of the use of narcotics that, as you know, is very high on this patient population, especially when they're having an active painful episode. I would like to change gears a little bit because, as I mentioned, bone marrow transplant at this point is our goal for cure. And here at Duke, we have been participating in bone marrow transplant research for a while. Initial bone marrow transplant studies really have been done in kids with sickle cell disease and other hemoglobinopathies. Sorry. And basically, this study where Dr. Keith Sullivan from the Duke transplant group here shows that when treating young kids with an HLA-matched sibling bone marrow transplant with this indication, having a stroke, having had survival, it's very high with an overall survival of 90%, but there is still a significant percentage of rejection and a chimerism and graft versus host disease that we don't want to give to these patients that we are expecting to live 40, 50, 60 more years. So we're looking more at the patient age for doing transplant on adult patients and really looking into how do we decrease complications such as graft versus host disease, and how do we increase the survival of this patient population without the active complication. So far, the studies, the bone marrow transplant studies on sickle cell disease has been very small and very few. And the main issues have been that, you know, as I mentioned before, not everybody responds to hydroxyurea. There's overall a lack of comprehensive adult care in rural and semi-rural community. There's a significant lifelong impairment and quality of life impairment of adults with sickle cell. And the survival, as I mentioned, with sickle cell in adults is very decreased. This table here shows preliminary early data on some of the transplant that has happened in adults with sickle cell disease. For example, here in Duke, and this is now our N is 3, we have transplanted 3 patients with peripheral bone marrow stem cells. Other places such as NHLBI have transplanted larger number of patients, mainly adults. Bone marrow transplant have also occurred, a few of them, but basically still we are looking into a very young adult population. The goal of bone marrow transplant at this point is really to do a non-myeloablative procedure. So instead of really what we traditionally do with a patient that have leukemia or the malignancy when we do a bone marrow transplant, which is wiping off the bone marrow with a strong chemotherapy and making that bone marrow catch the donor bone marrow and grow, we're trying to basically decrease the production of those red cells by the native bone marrow and give the patient a donor bone marrow that will allow them to become, instead of becoming complete with a normal hemoglobin, they will become a sickle cell trait, so they will become a chimeric. That will allow for less aggressive pre-conditioning therapy, and hopefully also less production of graft versus host disease and long-term complication for the transplant. And that is what we call, a nonmyeloablative component. And right now we have a protocol open for adults with sickle cell disease here at Duke, where we are looking into not only those patients that right now have a sibling match, but we're also looking for those that do not have a match to use it as a control in regard with health outcome and cost of care over time for this patient population. Wanted to shift gears a little bit again, because I think we have in our hands a very innovative, personalized tool to address issues with sickle cell disease. So a few years ago, our sickle cell study coordinator, who's a nurse and very intrepid and interested in IT, started to develop an app. We all have our phone, we use our phones for everything, and as you know, the use of mobile applications for managing our life has really increased in the last few years. So we decided to look into, will this be something that will be interesting in our very young population that are all the time in a phone or in a mobile type of tools, and what can we achieve with that? So the main reason to develop this, as I mentioned, was really looking to how do we monitor the patient health and patient complication without having them to come to us all the time. Part of it is because, as you know, we are in North Carolina, we have 100 counties, we are a large state, and 50% of our patient population live 50 miles or more from Duke. So, and even though they still bypass 4 hospitals in a painful crisis coming from Fayetteville to be treated here, we want to find tools to monitor some of their ongoing health, to improve their compliance, and to improve overall the medical care without their having to come here to check a PTINR once a week or all that, because there's either not a provider in the community that feel comfortable treating them, or the patient themselves do not feel comfortable being treated in their community. So the objective of developing and looking into this tool was basically to develop that mobile application tailored to sickle cell, and hopefully improve the symptom and management monitoring, improve patient-provider communication, and the ultimate goal is to improve disease outcome and quality of life. So this study right now is in phase 3, and I will outline the result of phase 1, which was basically to determine will this be something that our patients will be interested in doing, and basically designing something that will respond to their needs. The second phase was to basically test, is this something that can be used, that is user-friendly, and then look into more clinical outcomes. So in our phase 1, what we did is we asked the patients, and most of the patients had sickle cell disease. We asked them, do you have a mobile phone? And I apologize, this is doesn't reflect well, but 92% said that they do have a mobile phone. 81% said that they are very comfortable testing, using testing for health-related issues, and almost 80% report that they were comfortable emailing providers in regard to their medical care, and not only that they were comfortable, but that will prefer that way of communication versus phone or other ways of communication. So this next slide basically outlines some of the views that we have in our mobile application. With that mobile application, the patient is able to slide this scale and shows record how much pain, if any, they're having. They are able to say where the pain is located, and they are able to show multiple locations of pain. Also, they're able to record what intervention have they done for that pain, and one or multiple, and this is a way of how they record it. They're able also to communicate with the provider and for us to respond to their input by saying, based on the input that you have, we recommend that you do this or this. And we are able also to get geographic information such as temperature of the weather temperature, barometric pressures, and other data that we know affect painful episode and affect how patients do when having a painful episode. So some of the results of the second phase are outlined here. Basically, the patient, we gave this to approximately 30 patients, and we let them play with it for 28 days. They basically record that they feel that this application was easy to use, that they think that it will be useful to track pain and other complications from sickle cell. They felt that it was a useful tool to communicate with the provider, and they also thought that they will be willing to use it to manage their health. We're currently in phase 3. And basically, we have enrolled 8 patients to date, and most of them have completed 28 days or more. And what we have we're looking for is if this is something that patient can use over time. So what we're showing that so far there's a significant completion rate, and that the number of days completed is basically as expected. Again, we only started with a patient with SS disease, but we are hoping to extrapolate data from this study and initiated studies with larger number of patients where we can really personalize even more what we are asking for the patients to report and how we're going to interact timely with the patient depending on what they enter in that application. So some of the potential use of this application is that we can critically and timely do a surveillance of the symptoms, especially after the patients are discharged from the hospital. As you know, that's a critical time for our patient population. And we have shown a significant number of no-shows. The patient go home, but they live 80 miles from here, and for one reason or another are unable to come back to our appointment, and then when we hear from them 2 weeks, 3 weeks after, they may have not been able to fill their prescription, they may have had other complications that we didn't know about and that we could have acted on timely, they may have had some social issues in association with the time they were in the hospital that we could have impacted on, but that hopefully with this type of timely communication, we will be able to oversee. Again, one of our main goals is to increase adherence, not only to hydroxyurea, but to the other medication that they take in a regular basis, folic acid, pain medication, etc., antibiotics if they are discharged with that from the hospital. We're trying also to see what treatment are most effective for patients. And again, potentially, this application can be used when we are doing some of those drug development studies to get the data timely from the patient without having to, waiting for them to come to the next visit. And again, we are always looking to better identify risk factors to try to prevent the pain crisis, which are the acute complication of the sickle cell disease, and also prevent hospitalizations. And again, as I mentioned, monitorization of symptoms to prevent during drug therapy is very important. I wanted to include this a slide because I have been mainly talking about disease pathology issues associated with this patient care. But I'm very strong about all the psychosocial component of this health that through life on this chronically ill population affect their care. from depression, and Shelby helped us do a very nice study evaluating prevalence of depression on this patient population, neurocognitive issues, unemployment, sexual dysfunction, and also we have these issues with access to care. You know, where do they have their care? How often do they receive their care? Do they receive the most appropriate care? For example, we opened a day hospital a year ago here at Duke that allows for outpatient management of acute episode. So far, our data is showing that out of 10 patients that comes to the day hospital, 8.5 goes home and does not need to be admitted. And other places with day hospital have shown that these also represent decrease on costs and decrease of hospitalization. But at the same time, some of those day hospitals that have been self-standing for years now are closing because of issues with funding and issues with revenues. So we are interested in looking forward, how do we standardize that care? How do we really make those health cost decisions valid, not only for 2013, but for 10, 20 years to come? Dr. Edwards presented a very nice MLK presentation a few months ago, and he uses this very complex slide, but I think it just represents how complex is this disease, especially from the psychosocial point of view. With everything really, or a lot of surrounding pain, there is still a lot of psychosocial issues that we need to address. Socio-demographic, social support, disease prevention, perception of patient and healthcare provider about this disease. How do they cope with this? What happened with their body image, and how do the weight and all that affect this? And also, what other comorbidities that we see as patient age really impact this disease? And this is a big field of research that is basically in very early stages. So I wanted to conclude with outlining the cause of this disease is years of pain and suffering, loss of function and chronic morbidity and mortality, difficulty with social functioning and long-term quality of life, as well as high cost to the medical environment, and that is associated with shortened lifespan. Which means that what we offer now is compassionate, comprehensive care. We offer these patients some drugs to take care of their illness, and we offer, hopefully, the possibility of future development for research, both in the basics field, in the clinical field, and in the translational research. These two research basically outlines all the areas, or some of the key areas, where we still have a lot to do. We still have to do with gene therapy. We have to develop better animal models for preclinical studies. We need to learn to treat better patients in regard with blood transfusions and all that. We need to even look about what does sickle cell trait means. I don't know if you have been following the NCAA and the issues with athletes with sickle cell trait. We need to decrease the long-term medication, and again, last but not least, continue to address psychosocial studies in sickle cell disease. Dr. Tellen, my boss and my mentor, quoted this a few years ago, which I think that is still very true, that each step will get us closer to find the adequate therapy for sickle cell disease. Thank you.
Thank you, Laura. That was superb, and you certainly have set a platform for future investigation. Well, what is your plan? It seems that there are several areas that are in need, but as a group for the sickle cell team here, well, what are your plans?
So our interest really is continue to perform collaborative research. We have had a tradition of research with the psychologists and the group, or genetic groups, especially Christopher Edward and Alison Ashley Cook. But we have a tradition of doing basic science preclinical research, basically through the lab of Marilyn Tellen. Our goal is to do collaborative research on any area of sickle cell that makes sense. And one of those investigators that I'm not really in a niche of, I only do drug development and that's it. And that our team is kind of the same. Mm-hmm. We're interested in really. We have the tools of the patient population that traditionally is very actively participating in our research, is interested in supporting research, and we would like to continue to do collaborations on areas that other researchers feel that they can apport to this field.
It seems timely. Before I came down, there was a message from the NHLBI. You probably got it as well. It's an RFA for a U34. So these are monies to plan a clinical trial for rare thrombotic and hemostatic disorders. And like many, you have 90 days. So I think the receipt had to be in by October. But it sounds like some of your work with propranolol, depending on how the data look, and the data with the pan-selectin, which looks somewhat promising, that perhaps putting in a grant, collaborating with the UNC sickle cell group would fit very, very nicely into that U34 mechanism. And maybe the DCRI could help out providing a little bit of the operational infrastructure to make that happen.
Good.
So it's something worth considering.
Good.
So
that sounds like a good plan.
other comments or questions? Okay. Good. Please, Zubin.
Thank you for a great talk. It was a great overview of sickle cell disease, and I was interested in the mobile application you had developed. So I had a few questions. One was you're, storing or you're transmitting PHI with controlled substances, and I was wondering how you're handling that in terms of the communication of that from providers to patients.
Yes.
I was also curious about the visual analog scale that you use and if that's a validated instrument, and and the question of stickiness is, are you getting patients, if they weren't filling out diaries before, are they now doing this on the app? This same issue in heart failure, which I deal with, diabetes and other chronic diseases. Yeah. Thanks.
So thank you. They're all very interesting questions. So PHI is a very important issue for us, and make sure that the information is transmitted secure and appropriately, and that doesn't get out there, especially because of the controlled substances that the patients are using. So our platform is through the Duke system and is quite secure. And we are working, in fact, with the personalized medicine on improving our identifier and our security components. But this had been a concern and important component of this from the beginning. All the information comes to a server, a secure server, and from that server, the database is recorded and saved. The second part of your question was about the validation of the scale versus the VSA, the traditional scale. And I didn't have time to show all that, but we have done those validation studies. We have looked into those, whatever the patient slide with correlate with what, traditionally is the way to record pain from the 1 to 10 scale and all that. So we have done those studies. And so the last one was...
Is the stickiness in terms of the data entry from the patient side. Do you feel that there will be rate limiting steps just as there were with the diaries?
That's something that we're still evaluating. From what the patient report, it does look like this is something that they will be more interested in doing, and the early data that we have, very, very early, on what percentage of entry the patients are doing, looks like it's much better than the data that the pain diary data. But that's still something that we're looking for, on a study type of arrangement to really look into does this make sense? Are the patient using it correctly, and is the data appropriate enough and in enough amount that will give us a difference? Yeah.
Mm-hmm. Thanks, Dr. De Castro. That was extremely thorough, very good presentation. I wanted to know if the team, if you guys have approached by chance the DHI team, the Duke Institute for Innovative Technologies.
In fact, through Amy Abernathy, we have started
Okay.
to have conversations with them. Really, nothing really that strong at this point, but yes,
Okay.
we are that. Yeah,
Because I know that they have a series of workshops where people come and present, healthcare modalities, high impact research ideas, and it's been really, really neat.
Yeah,
to see
I
that,
think
and
we
they
need
have
to
such-
really address that more and pursue that area.
Yeah, that'd be great. But thank you. That
Thank
was so
you.
thorough.
Okay, well, thanks so much, Laura, for an excellent presentation.
Thank you.
Thank you all for your attendance.
Thank you.